So we're going to be going over the ankle exam today, which includes the AP, the oblique, the mortise, and the lateral. So the first thing you want to do is work from the outside in. So I have already had my technique book out and open. I'm going to set my technique for the AP ankle. 60 kV on this technique. 3 small focal spot, tabletop. I've already covered my mouse and my exposure button with Clorox wipes so I can continue to wear my gloves as I am taking my exposures. I already have an 8x10 already in the room. I have already measured to my 40-inch SID. So now all I have to do is get my tube and my part centered over my patient. So with this, we're going to make sure that we've removed any metal, any artifacts around the ankle area. We can bring the jeans up. They don't have to come off as long as they are not over the malleoli. So I'm going to raise her leg up. I'm going to put the center of her ankle in the center of the IR, so the ankle joint. I'm going to ensure that my central ray is at the center of my plate, side to side and top to bottom. I am going to have her dorsiflex, or I would tell my patient to bring your toes up like you're pointing to the ceiling. Right there is good. Place my marker on the lateral aspect. Now this is going to be hung with the tibia and fibula pointing down on the display monitor. So I'm going to put my marker so that it is also displayed so it won't show up upside down. I'm going to collimate in side to side, making sure my marker stays in the light. And then I placed a shield over my patient's lap for radiation protection. I have collimated down, and I'm going to measure my part at the central ray location to ensure that the technical factors are correct. Now when you do this, make sure that you are touching the bottom of the metal, should be touching the very back of her ankle. Do not have it, if there's a little gap here, do not have it touching the plate because we don't need to measure the air. We're just measuring the thickness of the part. Now if your patient happens to be upright, I would have them turn and look away, but I prefer to have my patient laying flat because that reduces the radiation to the eyes and to the thyroid area. So if you could just hold very still, I'm going to take this measurement around here and make sure that it matches up with my technique. And it's 1 centimeter off. And with the 4 centimeter rule, if I'm only 1 centimeter off, I can keep it the way it is. Hold very still. Beep. You can relax. I'm going to bring in my next plate. Now I grabbed a wipe so I can clean the plate that she just had her ankle and foot on. You can lift this up. I'll put this other one right underneath here. Go ahead and rest it back down. All right, so now I can wipe this plate down so that I can run it when I go back around the control panel. All right, now I'm going to do the mortise. And with the mortise, what I'm trying to do is open up the entire joint space between the tibia and the fibula and the talus. So what you do with this is you're going to internally rotate the patient's leg by about 15 degrees. And that is going to put your intermalleolar line parallel to the image receptor. When you perform the true AP, the fibular malleolus sits more posterior than the tibial malleolus. So we're internally rotating so that those malleoli are in the same plane and so that intermalleolar line is parallel to our image receptor. So a 15-degree internal rotation. Okay, my distance is still the same. My central ray is still going to be at the ankle joint. I'm just internally rotating. Collimation should be the same. Patients should be pulling their toes up towards the ceiling or dorsiflexing. Try not to say dorsiflex with your patients because they don't know technical terms. So we try to use layman terms with our patient and technical terms when you're speaking to another healthcare provider. So we're going to measure the ankle once again through the central ray location. We're going to take our old IR out. Please hold still, don't move. And I'm holding my IR, even though I have my gloves on, I'm holding it with a clean Clorox wipe, so my gloves aren't actually touching the clean plate. I'm then going to look at my technique and ensure that I do not need to change anything, and it's the same measurement as the AP was, so I'm good. Hold still. Beep, you can relax. I'm going to grab my new plate now. Now we're going to go on to the regular oblique. So when it is a 15-degree oblique, it's called a mortise. When it is a 45-degree oblique, we call that the oblique ankle. If you could just raise your leg up again, and put another plate underneath. Okay, go ahead and bring it back down. So I'm going to move my marker. Clean this plate off so I can bring it with me. Okay, I'm going to have you roll in again. This time we're going to roll a little bit further, and I'm grabbing above and below the area of pain. You don't want to grab right onto the ankle because that is where the patient is complaining of the pain. So we do not want to cause them more pain or more injury to the site. So you want to support above and below. 45 degree. I'm going to measure once again. Hold very still. And then hold my IR with the wipe once again. Take my measurement. I'm going to check and see and adjust, and I don't need to. Hold very still. Beep, you can relax. I'm going to grab a new plate, which I have already run. The next one we're going to do is going to be the lateral. So just like the foot, this is going to be a medial lateral. So I'm going to have the patient roll up onto your left hip, come and roll towards me. Raise up that foot. Okay, go ahead and rest it down. And this one back a little bit for me, please. Thank you. I'll place the shield back up over you again. Once again, just like for the foot, you may need to have a sponge or something underneath the knee to ensure that the ankle is in a true lateral position. Okay. Bring your toes up. Good. Turn the tube. Ensure that my IR and my CR and my part are all in alignment with one another. And we want to make sure that our collimation front to back is open to include the base of the fifth metatarsal, or the tuberosity, fifth tuberosity is included in the ankle because that is a frequently fractured location. I'm going to measure once again. This is considered a medial to lateral projection. So it's a medial lateral. And take this with me, and I will clean this when I get back before I run it. I'm going to check my technique against my measurement. Hold very still. Beep, you can relax. So then I would clean this plate, run it. I would go get my other plate, and I would clean that off and run it. And that is the exam for the ankle.